few issues with BT, and so I'd like to just do a sound check to make sure that everybody can hear me. So I wonder if anybody can. Okay, that's great. Okay, fantastic. We've been having some major issues here in Cambridge, so we were a little bit worried. Okay, that's great. Okay, so as I said, welcome everybody to today's webinar, and today I'm going to be talking about stress and the HPA-axis and how it impacts on neuroinflammation, with specific sort of focus really on sort of mood disorders, dementia, and those kind of areas. So if we kick off, okay, so before I kind of go into discussing the sort of detrimental impact of chronic stress, it's just worth sort of acknowledging that the human body is designed to experience stress, and the fight or flight response, or sort of acute stress response, is our inbuilt mechanism that allows us to deal with the sort of threats to survival, keeping us alert and ready and to sort of avoid potential danger. And some of these sort of stressors are actually generally quite beneficial in terms of enhancing cognitive function and sort of neurobiological systems such as the immune system and so on. But it's the chronic sustained stressors that we're not really sort of well adapted to cope with, and this sort of chronic stress that impacts on the HPA-axis, causing major overstimulation. And we get an increase in cortisol to the point where it's sort of excessive. We get an increase in inflammation with sort of detrimental impact through oxidative stress, through increased lipid peroxidation. And we sort of normally associate inflammation as a normal and necessary response to injury or infection, but chronic stress can also induce inflammatory response via upregulation of nuclear factor kappa B, for example, which then leads to increased levels of pro-inflammatory cytokines like interleukins, TNF-alpha, and these themselves can stimulate cortisol release, and this plays a vital role in sort of relating the whole inflammatory response. But it's the continued overactivation of the HPA-axis through cortisol and through pro-inflammatory cytokines that eventually leads to the normal negative feedback inhibition of cortisol. And these sort of prolonged elevated levels of cortisol then carry on increasing inflammatory cytokine levels, which then sort of further aggravates the whole HPA-axis activity. And we start to see issues with neurotransmitter sort of uptake. We see issues with neurotransmitter production. We start to see sort of changes in brain structure and function. So sort of excess cortisol, for example, can actually sort of almost eat away at the brain. It has a negative impact on sort of cell turnover. And then we start to see the sort of classic symptoms that are associated with chronic stress. So decrease in appetite, decrease in libido, we get weight loss, fatigue, sleep disturbances, impaired cognitive abilities, and depressed mood. So not awfully pleasant. What's quite interesting is that many of these sort of symptoms, such as weight loss, fatigue, and so on, are actually also associated with many physical illnesses. And these symptoms are known to result from sort of immune activation. So we've got our sort of, again, our pro-inflammatory cytokines, the pro-inflammatory ones, sort of interleukins, TNF-alpha, and so on. And this form of stimulation is really kind of called sickness behavior. And we can also see similar symptoms induced artificially. So, for example, in sort of experimental studies, we can use bacterial endotoxins. In human studies, we can give interferons, mainly given through sort of therapeutically for hepatitis C treatment, for example. And these, the inflammatory response that we see through these mechanisms can actually be successfully treated with standard SSRI antidepressants, for example. And this gives us the link between sort of inflammatory cytokines and the development of depressive illness, for example. So what we do know is that excessive levels of cortisol are extremely neurotoxic, especially in certain areas of the brain that are in, for example, in memory and learning. And as a sort of classic example of this are that we see with Cushing's disease, so patients with Cushing's disease who are exposed to excessive release of cortisol over long periods. Present with symptoms very similar. So we see symptoms of depression, anxiety, cognitive dysfunction, and so on. And it's quite interesting, a 1997 study showing 66% of Cushing's patients who exhibited these sort of symptoms after 3 months of treatment, in this case it was via surgery, the symptoms of anxiety and so on dropped significantly after to 54%, and then after 12 months down to 24%. So if you lower cortisol levels, you do sort of see an improvement in these kind of symptoms. The impact of cortisol on the hippocampus depends on certain factors. So, for example, the developmental stage of the structure of the hippocampus, so the age, for example, at which the sort of elevated levels of cortisol impact. So the younger we are, for example, when we are exposed to acute stress, the more detrimental it's going to be in later life. And then we have things like the level and sustainability of cortisol and the severity or the duration of the actual stressful event itself. And then we have different categories of psychological stress. And some examples here are things like altered mother-infant interactions. So children, for example, who are placed very early in foster care tend to have sort of issues with sort of depression and so on, and stress and anxiety later in life. The sort of classic chronic abuse, so physical and mental abuse. And then we have life-threatening situations such as sort of combat, natural disasters, rapes, etc. And then the sort of more classical ones that are experienced by the sort of general population as a whole, if you like. So things like financial issues, job loss, childbirth, even sort of getting married, all these kind of things can induce sort of chronic stress throughout the sort of average person's sort of lifespan. And so early life stress, so the earlier we have an impact of sort of chronic stress, so the younger we are, the more likely it is that we are going to exhibit symptoms associated with anxiety and depression, for example, and post-traumatic stress disorders are particularly interesting as well. PTSD, for example, sort of childhood physical abuse very early on predisposes for post-traumatic stress disorder later in life. And again, women with history of childhood abuse are more than twice as likely to develop depression as those women who have not been abused. So there's a sort of clear association between early life stress and later life sort of initiation of depression. And so this sort of dysregulation in the HPA-axis, elevated cortisol, brings around major changes in both brain structure and sort of function. And if we take sort of post-mortem studies, if we look at MRI scans of individuals who were depressed or who are depressed, we see that there are major changes in specific regions of the brain. And also there are levels of neurotrophin, so these are brain-derived growth factors that are heavily involved in neuronal survival and synaptic plasticity. So neurogenesis, for example, are known to be lower in patients with major depression, patients with bipolar depression, and we can see them through animal models of depression as well. So the sort of association between growth factors and sort of brain density almost as well. Another negative impact of cortisol is through long-chain omega-3 fatty acid metabolism. So cortisol directly inhibits both delta-5 and delta-6. that are involved in short chain to long chain omega-3 fatty acids. And again, there was an association between sort of depression and various other sort of stress-related disorders as well, with long-chain omega-3 EPA and DHA concentrations. The importance of this really sort of comes about when we start looking at the role of omega-3 in the various phases of inflammation and the stress axis itself. So during normal immune response, we get a release of pro-inflammatory products such as leukotriene B4, prostaglandin E2, which are known to drive the initiation of an inflammatory response. We then get an eicosanoid switch, and it's worth just noting as well that leukotriene and prostaglandins are derived from omega-6 arachidonic acid. And obviously the inflammatory response isn't an exhaustive process, so there has to be a very clear stop signal, and this sort of notes the sort of resolution time. And the relevance of long-chain EPA and DHA is that they are directly involved in initiating this stop signal. So it's the downstream products that are derived from EPA and DHA that are vital to initiate the sort of resolution of the inflammatory process. And so we think of EPA and DHA as anti-inflammatory, but actually they're also pro-resolving products. So if you don't have enough EPA and DHA within your cell membranes, then you're not going to be producing enough anti-inflammatory substrates to sort of get this sort of resolution of a normal inflammatory response. And this is where we start sort of seeing issues with sort of what we call silent inflammation, especially if you're not consuming long-chain omega-3 fatty acids as well. And so I've mentioned arachidonic acid. If our EPA and DHA levels are low, then our arachidonic acid levels are going to be sort of free to merrily along with sort of various inflammatory processes. And we see that the arachidonic acid content of red blood cells is directly correlated with pro-inflammatory cytokines such as interleukins and TNF alpha, for example. So it's not necessarily always the case that arachidonic acid levels are high. It's just that if your EPA levels are low, then your AA to EPA ratio, which is our biomarker of inflammatory status, is going to be unbalanced and in favor of arachidonic acid. And so the whole sort of interaction of omega-3 in sort of regulating stress and inflammation is really, really important. So just to sort of summarize, really, if our omega-3 levels are low, then this is going to impact on our AA to EPA ratio as well. So if your omega-3 levels are low, it's likely that your EPA levels are going to be low, and this will upset the normal sort of healthy balance of AA to EPA. And in fact, there is now an extensive body of data that shows us that depression is associated with both a chronic low-grade inflammatory response and through an activation of cell-mediated immunity. And so, as I've said, a high AA and low EPA will increase our inflammatory potential. And there have been several sort of meta-analyses also that have shown that omega-3 levels are significantly lower in depressed individuals as compared to sort of age-matched sort of healthy controls. And that actually our omega-3 index, or a low omega-3 index, and a high AA to EPA ratio can be directly associated with the severity of depression. And again, we can look at meta-analysis studies that show us that high levels of pro-inflammatory cytokines are also associated with depression and the severity of depression. And in fact, cytokines such as interleukin-1 beta, interleukin-6 are robustly associated with suicidality. And again, the sort of impact of increased inflammation and increased cortisol at a lower age can be seen when we look at sort of childhood associated depression in sort of young adults. So children who are exposed to inflammation and high levels of cortisol at a young age are at a higher increased risk of developing depression in sort of early adulthood. And so the sort of whole cytokine-induced depression theory can be proved as well. So we can take interferon alpha, for example, and we can give it to perfectly healthy people. And within about a week, individuals will start to show, some of the symptoms that are associated with depression, for example. So they become fatigued, lose their appetite, become socially withdrawn, want to go to sleep, just sort of general interest. And interferon alpha, oh, sorry, that's the wrong way around there, I do beg your pardon. So interferon actually also increases HPA-axis activity as well. So we also see increased cortisol, which again significantly correlates with both depression and fatigue. So we've got high levels of pro-inflammatory cytokines, we've got high levels of cortisol. Let's have a look at what it is that they are doing to sort of instigate all these sort of symptoms that we see. So one of the key things is that cortisol, pro-inflammatory cytokines, they shift tryptophan metabolism. This is our essential amino acid involved in sort of serotonin production. They shift tryptophan production away from 5-HTP and serotonin production through to kyurenine. Kyurenine then converts through to quinolinic acid, and through interaction with NMDA receptors actually starts to sort of literally cause neuronal damage. So we start to see cell death within the brain, and this is sort of where we sort of start sort of seeing issues with sort of atrophy and sort of brain shrinkage. So being depressed can actually make your brain shrink. And then through sort of low 5-HTP and low serotonin, we start to see issues associated with depression, and obviously serotonin, which is our precursor to melatonin. We're going to start to see sort of issues with sort of sleep disturbance as well. And so what's quite interesting is that omega-3s are known to interact or increase the activity of various brain nerve growth factors, for example. So we know that people who have high omega-3 intake have higher brains. They have increased and greater grey matter volume than sort of average average healthy people, for example. So people with the highest omega-3 intake will have the sort of fattest brains, if you like, and we can sort of show evidence to suggest that omega-3s are associated with nerve growth factor gene expression by actually sort of causing an omega-3 deprivation through animal models. It's a bit unethical to do it in humans, so unfortunately we sort of do it through animal models. But if you deprive rats, for example, from omega-3, so if you deplete their diets from omega-3, what you see is a decrease in frontal cortex omega-3 content, you get atrophy, and you get a reduced gene expression of various brain-derived growth factors. And actually this implies that there is a potential role of omega-3 in brain trauma as well, which I will talk about in a bit. So really, as a kind of a summary, increased chronic stress and how this leads into sort of atrophy and death of our neurons. So we have high levels of stress, we get increased activity of the HPA-axis, we get increased inflammatory cytokines, and if we have a low omega-3 intake, that's going to impact on our normal growth and survival of our neurons. If we have increased HPA-axis activity, we get elevated levels of cortisol. Cortisol is going to reduce our omega-3 metabolism by interacting with down-regulating delta-5 and delta-6. And again, this is going to impact on brain-derived growth factors as well. And the whole kind of summary of it really is that we get decreased dendritic branching, we get atrophy, and we get death of our neurons. So I've touched on serotonin production. Let's have a quick look at serotonin degradation. Okay, so serotonin, after exerting its action in the postsynaptic neuron, is transported back into the presynaptic neuron by the activity of specific transporters. And there it's then taken up into vesicles, and then it's metabolized, so it's degraded by those sort of monoamine oxidase, for example, and it's the ratio of serotonin through here that gives us an overall sort of estimation of serotonin activity. And so a high ratio here is going to imply that our serotonin activity, our serotonin uptake, and our serotonin degradation is going to grow as well. We know that depletion of tryptophan and decrease in serotonin product is a feature of mood disorders, but we also know that the activity of serotonin recycling, so the pro-inflammatory cytokines, and this impacts on our overall serotonin activity as well. So not only are we getting a decreased serotonin production, but we're getting an increase in serotonin turnover and degradation. And again, we can see this in animal models. Again, animal models are omega-3 deficient. And so at this point in my webinar, I'm just going to sort of summarize really by this little table here. So neuroinflammation in mood disorders, we get elevated levels of cytokines and cortisol through chronic stress. If you also have a high AA to EPA ratio and a low omega inflammatory sort of aggravation of the axis, and then we start to sort of see issues within sort of atrophy and sort of down-regulated neurogenesis as well. And we have all of our sort of contributors here as well. And all of these sort of mechanisms and pathways aren't just necessarily related to sort of mood disorders and post-traumatic stress disorder and anxiety disorders. We know that individuals who are depressed and who are clinically depressed for long periods of time, or who are exposed to cortisol from a very early age, and then this impacts on sort of depression risk, then are at a higher risk of developing dementia in later life. And omega-3 and dementia risk is also a big association there as well. Meta-analysis, a relatively recent meta-analysis a couple of years ago, showed that omega-3, EPA, strangely enough not DHA, are all significantly lower in patients with pre-dementia syndrome. And in fact, we put a lot of emphasis on DHA as the sort of major omega-3 fatty acid found within the brain. But actually, if we look at levels of EPA and DHA as in pre-dementia, what we find is that EPA levels are significantly related to dementia risk. And there is some evidence that if you sort of supplement with EPA rather than DHA, you get a better sort of brain effort in relative to cognitive performance, certainly in young adults as well. So there's a big difference between EPA and DHA, and I'll talk about that in just a moment. But what is really important when we're sort of talking about omega-3 in sort of cognitive enhancement, and we see this related to sort of mood disorders and cognitive sort of dysfunction as well, is that those individuals who have the lowest levels of omega-3 are more likely to respond than people who have higher levels. So basically the benefits that are attributed to supplementing with omega-3 are really kind of restricted to those who have suboptimal omega-3 intake. Okay, so post-traumatic stress disorder. It's a bit of a hot subject at the moment, and one thing that we do know is that there is increased interest in using omega-3s within the military setting. Certainly, a lot of this sort of evidence is coming from the US, and that we know that low levels of EPA, high AA to EPA ratio, so indicative of a pro-inflammatory sort of environment, is associated with the severity of post-traumatic stress disorders. And again, there's a big association between high levels of pro-inflammatory cytokines in individuals with PSTD as compared to those without PSTD. Post-traumatic stress disorder, we kind of think of it as a sort of psychological thing, but actually it can be brought about by sort of injury as well. 1 in 4 patients who go into intensive care units after sort of a major accident, example, are likely to develop PSTD. And so again, there is interest in using omega-3s in reducing the risk of developing post-traumatic stress disorder. And I'm going to talk about this particular study, just to go through a few studies now, just to sort of emphasize some of the relative sort of importance of omega-3 in sort of neuroinflammation, for example. This is a study that was published just this year, and it's really to sort of highlight the importance of getting the correct omega-3 for the correct condition, for example. So, as I said, this was published just this year. In fact, the paper is published from the same study, and the authors looked at DHA for the prevention of PSTD in severely injured patients. So they took 110 accident-injured patients, and they put them on a 3-month daily dose of just under 1.5 grams of DHA and 150 milligrams of EPA. Primary outcome really was looking at the score for clinically administered PSTD scale, and the secondary outcome was to include sort of diagnosis, so whether they went on to develop full-blown or partial PSTD. And then in the second paper, they looked specifically at the effect of DHA on brain-derived nerve growth factor levels as well. And they reported that there was no benefit in DHA supplements for the prevention of PSTD in severely injured patients. There were no differences between the CAP scores after 3 months. Interestingly, though, 11% of the DHA group compared to 5.5% of the placebo group actually went on to develop full-blown PSTD. And in their second paper, they actually showed that there were no changes in, or no benefit specifically from DHA supplementation on increasing BDNF levels. So the paper kind of sort of emphasized that DHA was not beneficial for sort of preventing PSTD, certainly in sort of injury. But if you actually delved into the paper a little bit more and had a little look at the omega-3 levels themselves, it sort of clarifies a few things centered around some of the issues that we have at sort of study design, for example. So, firstly, to point out, the population, or the target population here, was a Japanese population. Japanese are very well renowned for their high omega-3 intake. And if we actually just have a quick look at their omega-3 levels, so omega-3 index of 7.6 and 7.78 for the DHA and the placebo groups, this is actually just under the 8% target that we would define as being a sort of optimal omega-3 content within cell membranes. So it kind of reflects a high omega-3 intake. If we look at EPA and DHA within the sort of makeup of the omega-3 index, we can see that DHA makes up a significant amount of the whole sort of content of the omega-3 index, whereas the EPA levels in both groups was relatively low. And this then goes to reflect our AA to EPA ratio. So arachidonic acid levels aren't particularly high, relatively normal, but because EPA levels are low, then the AA to EPA ratio is going to be relatively high. So you could say that if they had sort of really sort of thought about this study a little bit better and maybe sort of switched it around and supplemented with EPA, which is known to be majorly anti-inflammatory, it's known to play a significant role in upregulating genes involved in neurogenesis, for example. EPA is also known to lower cortisol levels. If the study had been designed accordingly, then maybe we would have seen a slightly different outcome. And another study really to sort of highlight the importance of looking at study outcomes a little bit more carefully. So bipolar disorder, to schizophrenia, similar to clinical depression, is also associated with low red blood cell membrane EPA and DHA levels. DHA levels being the focus of this particular study. So they looked at individuals, compared them with healthy subjects, and they looked at their red blood cell membranes, and they looked at the association between DHA, EPA, and AA levels within the two populations. And they reported that DHA levels were significantly lower in the bipolar subjects than compared to the healthy subjects, although EPA, DPA, and AA were not different. So for those of you who aren't familiar with DPA, DPA is the omega-3 fatty acid that is in between EPA and DHA within the sort of metabolic pathway. Again, if we go and have a look at the fatty acid levels, what we find is that the arachidonic acid levels were actually a little bit high at 17, but not sort of excessively high. But if we actually look at the omega-3 index in both populations, both bipolar and healthy individuals, had incredibly low omega-3 index. So we would suggest that anything below 4 is going to put you at a significantly higher risk of poor health generally. Certainly in regards to sort of omega-3 index as a biomarker in cardiovascular disease, an omega-3 index of 4 and less puts you at the highest risk, and an omega-3 index and over is generally accepted as being sort of completely beneficial and sort of protective, if you like. So both populations actually have omega-3 indexes which would put them at a sort of increased risk of poor health anyway. And then we go back and we look at how much EPA and DHA makes up our omega-3 index. And again, EPA levels were incredibly low, really, really low. So this is on our AA to EPA ratio. So this would indicate really pretty unhealthy in regards to the sort of pro-inflammatory sort of status. So putting all your sort of focus on saying, you know, DHA levels are really low in this population is not probably reflective or truly reflective of the whole sort of study. So we have to be really careful in how we interpretate some of the findings when we're sort of looking at the evidence that is sort of presented to us. And if we're thinking about using fatty acids as an intervention, and sort of if you're a practitioner who already uses omega-3s, or if you're a practitioner who's considering using omega-3s, these sort of three really sort of key focus points are really important. So the first thing you need to do is look at somebody's omega-3 status. We know that people with the lowest levels are the best responders. So sort of testing possibly to sort of see who needs omega-3 fatty acid intervention in the first place is probably sort of key to therapeutic outcomes. And then we have to look at people's EPA versus DHA requirements. And a couple of slides back, when I'm showing you the Japanese population and their DHA levels were really, really high, what's the point of throwing DHA at a population of people where their DHA levels are really, really high in the first place? Because it's very unlikely that you're going to see any sort of significant impact. And then we have to look at the AA to EPA ratio. So again, looking at that study population, their omega-3 index was actually really high. And if you just looked at the omega-3 index, you may consider them to be relatively healthy in regards to their omega-3 status. But if your AA to EPA ratio is high, then it's going to put you at risk of elevated risk of inflammatory issues. So you need to have a look at EPA levels as well as DHA levels. And talking about EPA and DHA and understanding people's requirements and where the evidence lies. One of the clearest associations for EPA and EPA over DHA is certainly in the treatment of clinical depression. And there have been several meta-analyses, the most recent published just this year, showing that EPA, pure EPA, or certainly EPA and excessive DHA is extremely beneficial in treating depression. Certainly when people's omega-3 levels are compromised. So if your omega-3 levels are low and you supplement with EPA, then you are at a much better chance of seeing clinical benefits. And it's nice actually, and this is a study really from a few years ago, that we actually are beginning to see a few studies that are understanding that EPA and DHA are very different omega-3 fatty acids, and it's just really kind of an understatement to just keep calling them omega-3 together. We have to look at EPA, we have to look at DHA, and we have to get a better understanding of their individual unique actions within the body. And again, so this was a study published in 2012, 1 gram of pure EPA versus 1 gram of DHA really kind of clarifies the benefits of EPA intervention in treating clinical depression. So DHA and placebo at the top here, and EPA reducing the depression scores after 12 weeks. And in fact, one of the biggest issues that we have in a lot of the meta-analysis studies that are coming out is that the meta-analysis are focusing on omega-3 together and then not identifying the health benefits of pure EPA and pure DHA. And we're getting some very, very confusing messages in the media that we need to be very, very careful of. One of the biggest issues with meta-analysis is that as practitioners, we're treating individuals. So we are not treating populations, we're treating individuals. And so we need to treat people a more personalized approach. And again, EPA, just to highlight, is actually, and these are relatively old studies now, but just to highlight that EPA is as effective as Prozac in treating depression at 1 gram a day. Not only does it treat depression, also decreases cortisol levels as well. So why is it that EPA is so effective in managing the symptoms of depression? Because we know that the EPA to DHA ratio of an oil can affect the anti-inflammatory potential, and there's certainly enough evidence to suggest that EPA is more effective than DHA in most cases in reducing various inflammatory cytokines, interleukins, TNF-alpha, and so on. And so oils that have a high ratio of EPA to DHA are just generally more effective when we are targeting inflammatory related conditions. And so this is just a slide really to highlight some of the key mechanisms by which EPA is known to be beneficial in treating chronic stress disorders, bipolar disorder, schizophrenia, even sort of not necessarily dementia itself, but lowering the risk of developing dementia, so pre-dementia, sorry. So EPA has on its own been shown to improve the symptoms of treatment-resistant depression, which is rather nice. EPA, through various mechanisms, is known to reduce hippocampal atrophy, so there's a lot of interest in EPA in Huntington's, for example. EPA, if you take it as a supplement, bypasses delta-6 desaturase, so we overcome some of the issues with sort of cortisol deactivating or reducing the efficiency of delta-6. EPA increases the production of pro-inflammatory mediators, so downstream products of EPA are really important. EPA reduces the activation of phospholipase enzymes, so therefore we get a reduced release of arachidonic acid from cell membranes. From there we get a reduced production of prostaglandin E2, which is a major pro-inflammatory eicosanoid. EPA lowers cortisol. EPA decreases pro-inflammatory cytokine production. It's also involved in cell survival by upregulating various genes that are involved in sort of neurogenesis, neuroplasticity, and so on. So things like sort of brain-derived nerve growth factors, for example, as well. So EPA and the downstream products that derive from EPA have numerous benefits in sort of cognitive function, brain function, that can help with various conditions that are related to sort of brain function itself. And just as a little note here as well, this is a couple of slides to sort of show a little bit more evidence in the role of omega-3 in depression. So I spoke a little bit earlier about the ability for pro-inflammatory cytokines such as interferon to induce depressive symptoms. Now, currently interferon alpha is the only beneficial treatment for treating people with hepatitis C. Now, we know that around about 45% of individuals with hepatitis C treated with interferon will go on to develop full-blown depression. What's really interesting is that individuals with hepatitis C who have low omega-3 status, so they have a low omega-3 index and they have a high AA to EPA ratio, will predict their risk of depression. So people with hepatitis C with really low levels of omega-3 are more likely to develop depression through interferon treatment than individuals with hepatitis C who have higher levels of omega-3. And we also see that when you treat people with hepatitis C with interferon, we get an increase in chiuretin concentration, we get a decrease in serum concentrations of both tryptophan and serotonin. So we're getting to the bottom of all these sort of mechanisms, and we're beginning to be able to tie them all in together. And in fact, Hep C induced depression gives us a really good model to sort of experiment, if you like, with omega-3. And this is exactly what we see in this paper here. So the hypothesis was that if you increase the omega-3 index in individuals who are going to be treated with interferon, that you can reduce their risk of developing depression as part of their treatment. And so this was a 2-week intervention, so this is 2 weeks before these individuals were actually given interferon. So for 2 weeks they were given high dose of omega-3. So they were either given EPA, or they were given DHA, or they were given a placebo. And, right, so out of the EPA group, only 10% of the individuals went on to develop depression, compared to 28% of the DHA group, and compared to 30% of the placebo group. So pre-treating with EPA significantly reduced the number of individuals who went on to develop full-blown depression. And of those that went on to develop depression, the week of onset, so it took 12 weeks for the EPA group, 11.7 for the DHA group, compared to 5.3 weeks for the placebo group. So EPA not only reduces the amount of people who go on to develop depression, but actually delays the time it takes. So all good stuff, really. And EPA actually also, not only did it both increase EPA and DHA levels, whereas DHA only increased DHA levels. Okay, so we know that EPA can reduce the risk of developing depression, certainly in people who are sort of omega-3 compromised. And it's important to emphasize really that if you're treating an inflammatory related condition, or an inflammatory, if you believe that it's inflammatory related, then if there is no inflammation, then we need to sort of reconsider our sort of intervention. And this was a study that, again, this was published this year, and it was really to kind of set out to look at the benefits or the effects of EPA in a population of people depending on their inflammatory status. So they took some inflammatory measures, so they looked at things like interleukins, CRP, they looked at leptin and adiponectin, and they kind of categorized the people as to those who were high inflammatory and those who were in a low inflammatory. And then they subjected them to 8 weeks of either EPA or DHA or a placebo. And then they looked at the outcomes. What was quite interesting was that overall, there were no sort of group differences between either the EPA, the DHA, or the placebo with any of the high inflammatory. However, subjects identified as being high, so those subjects who were considered to be at a sort of higher inflammatory risk, responded better than on EPA, than to those that were allocated to the DHA group. So, in summary, really, the outcome was that EPA supplements are more likely to be effective where there is pre-existing inflammation. And so there are lots of kind of factors that you need to take on board when you are considering sort of intervention. And we launched our Optio-3 fatty acid biomarker test last year, and it's been incredibly popular with practitioners. And it's a method really for sort of personalizing omega-3 fatty acid dosing according to your client. And so we give you an omega-3 report. We tell you what your omega-3 index is, your omega-6 to omega-3 ratio, and we give you an indication of your AA to EPA ratio as well. And all of these biomarkers are sort of indicative of sort of various aspects of health. So our omega-3 index is generally associated with cardiovascular risk. We throw the omega-6 to omega-3 ratio in there. It's well established, again, for long-term health and chronic illness risk. And our AA to EPA ratio, which is our measure of silent or chronic inflammation. And there's a direct correlation between the omega-3 index and the AA to EPA ratio. So if your omega-3 index is low, it is very likely that your AA to EPA ratio is going to be high. We then give you a personalized plan that, based on your client's omega-3 baseline levels of omega-3, to achieve an omega-3 index of more than 8%, to reduce their AA to EPA ratio between 1.5 and 3, which is the sort of beneficial sort of areas in regards to sort of omega-3 status. And given the sort of evidence for EPA in sort of mood disorders, in sort of pre-dementia risk, in conditions such as bipolar, PTSD, and so on, we recommend our restore and maintain protocol. So we recommend a minimum of 3 to 6 months on a pure EPA protocol, and this is really designed to lower the AA to EPA ratio, so we start to sort of see inflammatory regulation, support symptoms that are related to inflammatory illnesses, and it's just generally good for sort of optimum well-being as well. So after a minimum of 3 to 6 months, we would then suggest that you move over onto our maintain. So we then introduce DHA for structural support, and GLA as our anti-inflammatory omega-6 for a little bit of extra anti-inflammatory support. So GLA and EPA work together incredibly efficiently to sort of maintain a good inflammatory status or sort of anti-inflammatory status. And so again, sort of going back to my earlier slide, sort of highlighting the importance of treating with sort of pure EPA and then moving on to EPA and DHA to sort of balance our sort of elevated immune and inflammatory activity. And through this protocol, we will start to see, or you should start to see, sort of improvements in all of these areas. So where there was increased HPA-axis activity, this will be reduced. It will reduce cortisol production, and so on. However, it's also important to understand, and we're seeing this in sort of evidence that's coming out as well, is that it's unreasonable to assume that one nutrient is going to be responsible for sort of a sort of holistic approach, a total holistic approach to treatment, because omega-3s on their own are known to be beneficial. Actually, sort of adopting things like a healthy methylation cycle is also necessary for the production of SAMe, for example, which is involved in the metabolism of neurotransmitters. We need to ensure a healthy methylation cycle for things like cysteine and glutathione production, involved in sort of the transformation pathway, important for sort of protection and detoxification, and so on. So lots of factors here, things like vitamin B6 and vitamin B12, folate, are all involved. And so, as I was saying, it's some of the evidence that is sort of coming out that is suggesting that we need to sort of be looking at sort of nutrition more of a whole sort of holistic approach. And this is a paper that was published relatively recently as well, that was suggesting that brain atrophy in cognitively impaired elderly, they highlighted the importance of this sort of synergy between omega-3 fatty acids and vitamin B status as an example. And they showed that the beneficial effect of B vitamins, so they were looking primarily at high homocysteine levels and the impact of B vitamins in reducing homocysteine, homocysteine itself being a risk factor for sort of cardiovascular disease and dementia risk. So they were looking at the benefits of using B vitamins to reduce homocysteine and to reduce cognitive decline in the elderly. And they found that the benefits of B vitamin treatment on brain atrophy was only really observed in subjects with the highest levels of omega-3 fatty acids. So if your omega-3 fatty acid levels were compromised, supplementing with B vitamins wasn't really going to add that much value. So we have to start sort of looking at everything as a whole. And for practitioners who are familiar with iGen, you're probably aware that we did have a product relatively recently called Homocysteine Control, which we did recommend alongside our Restore and Maintain protocol as a sort of methylation support product, formulated primarily to help regulate homocysteine levels, for example. We have since relaunched our Homocysteine Control, and we have brought out a wonderful new product called Super B Complex. We've still retained the levels of B6, B12, and folate, to those levels that are known to reduce homocysteine levels, but we've added all the other B vitamins in there to give you a nice sort of highly bioavailable, sort of comprehensive, sort of full spectrum B-vit support. So as with iGenis, always we go for bioavailable, we go for proven dosages, and we go for efficacy. So where possible, we've used the very best ingredients. So we've used pyridoxal 5-phosphate, we've used riboflavin 5-phosphate, and we've also introduced our folate as methyl tetrahydrofolate as well. So I think at the moment, certainly within the UK, but it's the only product that has a B complex that actually incorporates methyl tetrahydrofolate. So again, we go for our split dosing. This helps to overcome B12 issues with bioavailability. And it's formulated for both adults and children aged +7, so it's a 1 tablet a day for children 7 to 16, and then we recommend 2 tablets a day for adults, and as I've said, we take it as a split dose. And just sort of coming to the end of today's webinar, just to sort of remind you of our iGenis Mind Care comprehensive sort of brain-targeted nutrition supplements. As I've sort of stated, you know, omega-3s, high levels, high doses are incredibly important as sort of therapeutic intervention, but we've also sort of got a range of incredibly well formulated products that are suitable for sort of more general health. We are finding that a lot of our practitioners are actually sort of co-supplementing alongside our Restore and Maintain, actually, because these account that not only do you need EPA and DHA long term, but actually a sort of comprehensive micronutrient and specifically targeted micronutrients as well. Can help in certain areas of sort of brain-targeted health. So our Mind Care Balance, for example, has the benefits of magnesium and glycinate and threonine. Our Focus, we incorporate taurine and threonine and caffeine. We get the micronutrients throughout. And then for those individuals who maybe not needing sort of comprehensive support for depression itself, but who just want to sort of stay on top of things a little bit, we've got a 5-HT and magnesium glycinate product. And then sort of Mind Care Protect, so our highly popular sort of anti-inflammatory EPA and DHA. So we've got alpha-lipoic acid, we've got some resveratrol in there as well. So we're catering for not only the sort of therapeutic hard area, but we're also got some incredibly good incredibly good products out there for sort of more aimed at general health and sort of keeping everything ticking over long term, really. Okay, so at this point, I'm going to sort of draw the webinar to a close. If you have any questions about any of our products, any of our new products, any of our therapeutic sort of interventions, please feel free to get in contact. This is my colleague Sophie, who is our education manager. She'll be able to give you any information at all on sort of any of the sort of areas, so certainly sort of therapeutic information. If you want any technical support, please feel free to contact me. I'm just going to have a look at the text box now and see if there's anything that I can help you with here on the clinical level. Right, okay, so let me have a look through these questions and let me see if I can. Yeah, okay. Yeah, actually, Robert's making some really valid points here about some of the sort of inflammatory states, mechanisms of this part. Yes. Absolutely, yes. Omega supplementation during, well, actually going into pregnancy well nourished is probably advisable, but that may not always sort of be how things pan out, as it were. But yes, getting plenty of omega-3s during pregnancy and during breastfeeding is incredibly important, and certainly for the first sort of few years of a child's sort of development, getting adequate levels of omega-3 is really important. And yes, as you've stated, there is a certain amount of sort of programming that goes on, and omega-3s are known to sort of genetically program sort of fetal development. So yes, it's a really valid point. Farmipa, both our Farmipa, Restore and Maintain, the capsules are made of fish gelatin. Okay, hi Andrew. Yes, in regards to conditions such as ADHD, ADD and so on, working memory, it's quite interesting again, if I go back to one of my slides as well, is the sort of association between the tryptophan and kynurenine pathway, because we see this in a lot of children with ADHD as well, in that their kynurenine to tryptophan ratio is really, really high. And again, the evidence for ADHD certainly points more favourably in the area of EPA. In fact, we had a very nice study published a few years ago using one of our products called Vijipa that showed very nice, clear, significant benefits in managing many of the symptoms associated with ADHD. Okay, so like I said, please feel free to get in contact. Myself and Sophie will be incredibly happy to answer any questions if you want to get in touch directly, or if you want any information on any of our products. Our webinar, as always, will be available shortly. And so until next time, I will say enjoy the rest of the day and have a good weekend. Oh, right, okay, very quickly. Haley, the product that was used in the ADHD trial was called Vijipa, but our pure EPA product, which is our sort of more concentrated, highly bioavailable version of EPA, is probably just as effective. And we have several sort of ADHD specialists who certainly would recommend our pure EPA product. Okay, many thanks.